you, Mr. Chairman, for this opportunity to present this topic. We will get back to cancer cervix again. There is initially some definitions I want to start with. We should differentiate between persistent disease and recurrent disease. Persistent disease is defined as the presence or a reappearance of the disease within 6 months from the definitive treatment, while recurrent disease is defined as appearance of the disease after 6 months from the definitive treatment. As we all know, one patient from every 3 patients will develop recurrence or metastasis after within the first 2 years from the definitive treatment. In this lecture, I will address the following questions. Should we use single or combination treatment? What is the best combination that we can use? Who responds better to treatment? Duration of treatment? And then I will discuss the role of targeted therapy in treatment of metastatic or recurrent cancer to cervix. The first chemotherapy which will show activity in recurrent or metastatic cervical cancer was the platinum chemotherapy, whether used single or in combination. So the platinum molecule is the cornerstone chemotherapy used in the treatment of cervical cancer. This is another trial of chemotherapy used in the recurrent metastatic cervical cancer, the GOG-43 trial, which was the results appear in 1985, where about 170 patients were randomized to 3 different protocols of cisplatin, fractionated cisplatin of 20 milligram per meter square from day 1 to day 5 every 3 weeks, versus small dose cisplatin 50 milligram per meter square every 3 weeks versus high dose cisplatin 100 milligram per meter square every 3 weeks. This arm of fractionated cisplatin was closed early due to long hospital stay with no statistical difference with the 2 arms in interim analysis. So this arm was closed early. At the end of the trial, all the patients received cisplatin cumulative dose of 400 milligram per meter square, but this was guided by patient tolerance. And the last results of this study, they showed that no progression-free survival or overall survival difference between the low dose cisplatin and large dose cisplatin, but sure in terms of toxicity, the low dose cisplatin was better and better tolerated by the patients. The response rate between the 3 arms ranged from 20% to 31%, with complete response rate ranged from 8% to 12%. So lower dose cisplatin is now the standard dose used in metastatic or recurrent cervical cancer disease. This is one of the combination treatment which used in recurrent or metastatic cervical cancer, where they randomized the GOG-169 about 460 patients into 2 arms. The first arm was cisplatin single agent, which is the standard cisplatin 50 milligram per meter square every 3 weeks for 6 cycles, versus patient received cisplatin in the same dose with paclitaxel 135 milligram per meter square continuous infusion over 24 hours. This study was well randomized and randomized in 1:1 ratio. The response rate, progression-free survival, overall survival, and quality of life were assessed in this trial. As we show here, that the addition of paclitaxel increased the response rate, doubled it from 19% to 36%, and also the complete response rate increased from 6% in the single arm to 15% in the combination arm. And also the combination arm overcomes the resistance of recurrent metastatic cervical cancer, which is known. In the single arm, only 19% respond to the treatment, with 81% of the patient didn't respond to the treatment. While in the combination arm, 64% only didn't respond to the treatment. So the addition of paclitaxel to cisplatin overcomes the resistance of non-cancer cervix to usual chemotherapy. Here is the graphs of progression-free survival, when we showed that addition of paclitaxel increased the progression-free survival by 2 months, and this difference was statistically significant, highly statistically significant. But unfortunately, this study didn't show any improvement in the overall survival of patients. And this study dramatically unexplained the cisplatin single arm overall survival was 9.1 months, which is over than any expected overall survival recorded in the old GOG 43, where the overall survival was about 6 months. And also in the GOG 179, the overall survival of cisplatin single arm was 6.9 months. But in this trial, the single arm cisplatin showed overall survival of 9.1 months. And the combination arm showed 9.9 months. So these show non-statistically significant overall survival. In terms of toxicity, grade 3 and 4 toxicity were comparable, but with controllable statistically significant higher neutropenia and anemia in the combination arm. Also in this trial, quality of life in the two groups were assessed, and the two groups was comparable with no difference in the quality of life of the two groups. The other combination chemotherapy which was assessed in the GOG 179, where about 300 patients were randomized to cisplatin single agent with the standard, which is a standard treatment, versus cisplatin topotecan. And the third arm was MVAC, but this arm was closed early also due to high mortality rates, so it is not allowed to use this combination treatment in the treatment of metastatic or recurrent cervical cancer. This was the first study that showed an overall survival benefit of a combination treatment versus a cisplatin single agent. The response rate was doubled in the combination treatment, 27% versus 13%, and the complete response rate was 10% versus 3%, and this was statistically significant. There was a statistically significant improvement in the progression-free survival and overall survival in this trial, and this was the first time to see overall survival benefit in any combination treatment over cisplatin single agent in cancer cervix. We will go now to the second question, which is what is the best combinations that we can use in the treatment of metastatic or recurrent cervical cancer. In the GOG 204, they randomized 500 patients into 4 different protocols of cisplatin combination, cisplatin paclitaxel, cisplatin topotecan, and then the new cisplatin vinorelbine and cisplatin gemcitabine. In this trial, in interim analysis, this trial was closed due to futility analysis. They show no superiority or inferiority of the 4 arms, with trend of better response rate, progression-free survival, and overall survival in the cisplatin paclitaxel arm. But this difference was not statistically significant. As we show here, this red line is the cisplatin paclitaxel arm, and this is the other groups. This difference, cisplatin paclitaxel was better in terms of progression-free survival and overall survival, but this difference is not statistically significant. Then we added the clinical trials, what is the best platinum that can we use in the combination treatment. As we know, cisplatin is a very toxic cisplatin is a very toxic chemotherapy with high side effects on the GI and the stomach. So they are trying to replace cisplatin by carboplatin. The first was a retrospective analysis by MD Anderson by Mori et al. In 2007, where he retrospectively analyzed 62 patients who received cisplatin plus paclitaxel versus carboplatin paclitaxel. And they concluded that both arms are comparable with better response in the cisplatin arm, the carboplatin arm in previously exposed patient to cisplatin. As we know that the patient with cervical cancer received usually definitive concomitant chemoradiotherapy, and they use cisplatin in these concomitant regimens. These patients, when they develop recurrence or metastasis, usually respond better to carboplatin, better than cisplatin. In a prospective study published in the ASCO 2012 by the Japanese group, they randomized 250 patients into 2 groups, 2 arms of chemotherapy, cisplatin with paclitaxel and paclitaxel with carboplatin AOC5. And in this study, the carboplatin arm was not inferior to the cisplatin arm and was comparable in terms of response rate, progression-free survival, and overall survival. They concluded that carboplatin paclitaxel is not inferior to cisplatin paclitaxel with better tolerance and compliance. And this is the progression-free survival curves of the 2 arms and the overall survival of the 2 arms, and we can see that they are almost the same. But they did an interim analysis or retrospective analysis of patients who exposed prior to platinum versus, and patients who didn't respond prior to platinum. Patients who are chemo naive or didn't receive prior chemotherapy respond better to cisplatin or not carboplatin. But this was not statistically significant. P-value was not statistically significant. And on the other hand, patients who were exposed to platinum previously, whether as an induction therapy before surgery or in a concomitant chemoradiotherapy, respond better to carboplatin R. And this was statistically significant. P-value was very low. The other question will be who do better? Who is the patient that respond better to chemotherapy? This is the GOG. This is the GOG 179 trial, and here there is subgroup analysis of the patients. We showed that patients who are chemo-naive, who didn't receive any prior chemotherapy, did better in terms of progression-free survival and overall survival than any other patient who received any prior chemotherapy. Also, this was confirmed in the Japanese trial that showed that patients are chemo-naive respond better. Duration of treatment, and this question, I think all our patients asked us, I will receive how many cycles? In all the randomized trial, this question was addressed, and the GOG 43 trial, this was the only trial that I read that specified a specific cumulative dose of cisplatin, 400 milligram per meter square. But in all the GOG trials after that, 169, 179, and 204, the patient received 6 cycles in non-responders, and if the patient is still responding, they continue until progression or unaccepted toxicity. So now we can continue for chemotherapy until progression, no limit, no upper limit, and no cumulative dose. My last question that I will answer is the role of targeted therapy. This is the cancer cells of the cancer cervix, and this is all the potential targets that are available. The vascular endothelial growth factor receptor and the factor itself, the hepatocyte growth factor, the epidermal growth factor, the insulin growth factor, and all these are the potential targets that can be used in cancer cervix. Some of these targets are addressed in phase 1 or phase 2 trials, and I will sum up some of the trials that talked about targeted therapy. Bazopanib, which is an oral anti-angiogenesis, targeting the vascular endothelial growth factor receptor, this one. And also we target platelet derived growth factor receptor and the CCAT pathway. Epidermal growth factor receptor and the HER2 new are also rational targets for treating advanced and recurrent cervical cancer. And these molecules, which is EGFR and the HER2, when overexpressed in cervical cancer, it is of very bad prognostic value. Lapatinib is an oral small molecule dual tyrosine kinase inhibitor for both EGFR1 and HER2 new receptors. Cetuximab also is an IV monoclonal antibody that targets the epidermal growth factor receptor. The other chemotherapy that can be used as a target is bevacizumab, which is monoclonal antibody against the vascular endothelial growth factor. Cetuximab was addressed in several clinical trials in the treatment of recurrent metastatic cervical cancer. In the GENICO trial, which is phase 2 trial of cetuximab plus cisplatin topotecan. This trial was negative trial, and cetuximab didn't add any benefit to the chemotherapy, standard chemotherapy. The median progression-free survival and overall survival was 170 days for progression-free survival and 220 days for the overall survival. Also, this was addressed, and also in this trial, the combination arm show a very high serious toxic events, and the fatal events had happened in this trial. Another GOG trial using cetuximab single agent failed to show any activity in metastatic cervical cancer, so cetuximab has no role in metastatic cervical cancer. Targeting vascular endothelial growth factor pathway, in this trial, 230 patients who were randomized to bazopanib, which is an oral vascular endothelial growth factor tyrosine kinase pathway inhibitor, versus lapatinib single agent, which is epidermal growth factor and HER2 new tyrosine kinase inhibitor, versus the combination in 2 different schedules. But this combination was closed early due to non-superiority to any of the single-arm groups. In this trial, the progression-free survival and overall survival was statistically significant higher for the patient who received bazopenib single treatment versus labatinib in terms of progression-free survival and overall survival. The second target served is a true activity in cervical cancer was the bevacizumab, and the final results of GOG 240 trial was announced in the ASCO 2013 this year, where 450 patients were randomized to cisplatin paclitaxel, topotecan paclitaxel, and this was the first time to use non-platinum combination in the treatment of recurrent or metastatic cervical cancer, versus one of them with bevacizumab. But bevacizumab here is used in a large dose, larger than the doses we used in breast or lung, which is 15 milligram per kg. Usually we use 5 or 10 milligram per kg in the colon cancer or breast cancer, but this is very high dose. Topotecan paclitaxel, which is non-platinum combination, was not superior or inferior to the cisplatin paclitaxel arm. The response rate was 48% in the chemotherapy bevacizumab arm versus 36% in the chemotherapy alone arm, and this was statistically significant. The hazard ratio of this was 0.71 in favor of bevacizumab, and this was statistically significant. Bevacizumab improved overall survival, and this was the second trial that showed overall survival benefit in any combination in the treatment of cancer cervix. Median survival was 17 months in the bevacizumab arm versus 13 months in the chemotherapy alone arm. Treatment with bevacizumab was associated with a lot of grade 3 and 4 toxicities, including bleeding, thrombosis, and GIT fistula. So this protocol should be cautiously taken into consideration. Another bevacizumab combination, which was bevacizumab with topotecan cisplatin, this was evaluated in a phase 2 trial, and this protocol was highly active with 74% of clinical benefit, and 39% of the patients show a stable disease. The median progression-free survival was 7 months, and the median overall survival was 13 months. But this protocol was very toxic, and we cannot encourage patients to receive this protocol. I think bevacizumab cisplatin paclitaxel is better. The last question is what we can salvage a patient in this